Hey guys, welcome back to another video. In this one, I'm going to show you how to critique and interpret humerus x-rays. I want to go through 5 different examples showing you what to look for, if it's good or bad, and if you see any pathology. Of course, using the PACEMAN image evaluation criteria. Let's go. Okay, so in this case, we have a left humerus as indicated by the marker, which is correct. And any long bone is defined by the 2 joints that flank it. Okay, so in this case, it'll be the shoulder joint and the elbow joint. Obviously, the shoulder joint is over here and the elbow joint is on the bottom. So we have everything that we need to include. Okay. Now, there are some sort of things that could be improved definitely in this x-ray, but that's what we're looking at, a left humerus x-ray. That was very likely done with the patient standing up against the upright bucky. Now, talking about the positioning, how well is it positioned? Okay. Well, it's pretty good. However, there are some things that could be improved. On the top over here, it's actually not too bad. Generally, what you find is that when you ask your patient to have their back against the bucky, you get their arm not necessarily straight down, but kind of out like this. Okay, so again, to kind of take advantage of the diagonal length of the detector, if need be. In this case, it doesn't look like it needs to be because the patient is not a full adult, and I can tell that by looking at these growth plates over here. Okay, so all these little growth plates, they tell me that this is probably a late teenager, something like that. Anyways, so the positioning is good on top. However, on the bottom, it's actually overlapping with the skin of the abdomen or the hip area. So that isn't ideal. It'll be better if the elbow was slightly pushed away so there wasn't that kind of overlap that we see on this x-ray. The humerus looks like it's in AP profile, so that's pretty good. Happy about that. Position good, could be improved. In terms of area, the area that's covered, we said earlier that it has to cover at least the shoulder and the elbow joints, and by definition, if you cover those joints, then you have the entire long bone on there. So top to bottom is pretty good, and side to side could be improved. Okay, and we'll talk about area is done, covered everything that you need to, not necessarily cutting anything off. Perhaps you can make the argument there, but it's just some skin overlap, nothing too major. In terms of collimation, how much collimation has this x-ray included? Top to bottom is then, again, not too bad. The bottom is definitely very good. Top, you really don't need anything from the shoulder skin margin, but side to side could definitely be improved. Okay, so anything from here on in, not needed. Anything from here on in, not needed. So top to bottom could almost have stayed the same, but side to side could have definitely been improved. Now, I always like to say, what is the centering of the humerus? And when you're looking at your patient, it's very easy to just center sort of mid-bicep area because that's what you see. However, it's important to find the elbow crease, which would be sort of around this area, and then find the top of the shoulder, which will be around this area, and find the midway between that. Okay, so midway between that is roughly sort of there, if you will. Okay, and that is a little bit higher than the mid bicep because the bicep goes from here to about there. So normally mid bicep would be there, but ideally should be centered higher and therefore collimated to include at least 1 or 2 centimeters from each end. And side to side, again, 1 or 2 centimeters from the skin border is more than enough. So collimation done, but could be improved. In terms of exposure, again, the humerus itself is very well exposed. If you sort of zoom in, you can see nice bone texture. The contrast levels are actually quite good. I can see the textures of the bone in there. So I'm happy with that. Now, the issue comes, well, not rather the issue, but you'll see that sort of these areas, is underexposed. But that's not the point because they shouldn't have been included in the first place. Okay? You shouldn't be including a chest, abdomen, rib x-ray, and almost like a pelvis when you're doing a humerus. So obviously ignoring that area, looking at just the humerus itself, the exposure is actually quite good. So I actually really wouldn't change the KVP and MAS. What about marker? So we see the marker that's digital left over here, correct? Ideally, I would have put the marker a lot closer to the anatomy. I like to just put it right next to the sort of top of the shoulder where there's some free space and cone it in side to side. Even in post-processing would have been better than this. So the marker is correct. You don't really need to say that this was done erect because that's the assumption. If it was done supine, you could add that in if you needed to, otherwise no need. Now the next is aesthetics. How's the aesthetics of the image? Could be improved. The main thing was the collimation side to side. If that was fixed, that would even improve the exposure to more than what it was. Now, if you zoom in, you can actually kind of see all these little faint little lines over here. Okay, see these faint little lines? What do you think that is? It's the sleeve. Patient's sleeve has been rolled all the way up and you can kind of see they were probably wearing something quite thin, but still shows up on x-rays. Okay, so all these little squirrely lines that go across the humerus, those are the patient's clothing, which ideally should have just been taken off if you want a nice and clear x-ray. Now, is it obstructing anything? Not necessarily, so definitely no need for repeat because of that, but ideally it should have been taken off. And lastly, name. No name or identification is seen because of anonymous reasons. Now, what about the pathology? Now, we talked about the artifact really that was the clothing, and probably the reason that it wasn't removed was because the patient had a lot of pain. Now, hopefully you've been able to spot the pathology. It's actually a little bit higher in this case. Okay, so these are growth plates, but that is not a growth plate. Okay, so that is what we call a surgical neck fracture of the humerus. It's borderline humerus or shoulders, but it's still part of both systems. But essentially, a fracture through this area would be called a surgical neck fracture because it goes through the surgical neck of that bone. And if you had to describe it, it's almost like an irregular transverse fracture of the long bone. Other than that, I don't really see anything else, so happy with that. Let's move on to the next one. Okay, so here's case number 2. Again, what do we see? We're looking at a left humerus x-ray, similar to the last one, as indicated by the marker and the position of the humerus. Now, let's see how it's positioned. Okay, so P for positioning. Pretty good positioning. I would say it's still in the AP profile. Obviously a big elephant in the room, which we'll come back to. But again, in terms of how it's positioned, the elbow is slightly away from the torso there, so that's quite nice. It's not overlapping with the skin as we saw before. However, there are other issues at play over here. Now, talking about the area, so is enough of the area covered? Well, again, we said the shoulder and the elbow x-ray should be covered. We see the elbow x-ray, so that's the elbow crease, that's definitely covered, but the top is not covered. We're kind of cutting off the shoulder. Now, would you repeat in normal circumstances? In normal circumstances, yes. But would you repeat in this circumstance? Probably not, okay? Because you see the actual issue that the patient has come in for. Now, in this kind of x-ray, we refer to as diagnostic, as in it's not the best, but it's answered the clinical question that likely the patient had come in for. So not ideal in terms of area covered, however, still pretty good for this particular case. In terms of collimation, again, the centering could have been done a little bit higher, opened up the collimation top to bottom to include the top of the shoulder. As we said, not necessarily needed in this case, but side to side could have been also improved. Okay, so all this area here, not needed. All this area here, not needed. Now this part's okay. This part could definitely be improved. There's a lot of sort of empty space that doesn't need to be there. What you can even do, because the anatomy is sort of at a diagonal line, you can rotate the LBD, the light beam diaphragm, to match the anatomy and then cone in more side to side. Okay, so collimation done, could be improved. Exposure. What do we think about exposure? Again, looking at the humerus itself, it seems pretty good. I see adequate contrast, I see adequate bone texture, there seems to be very little noise from what I can see, so definitely exposure is quite good, whatever they have used, plus or minus a grid, probably they have used the grid, but I wouldn't change anything about the exposure because it seems to be demonstrating the anatomy quite well. Marker, definitely we see the left marker here, which is correct. Again, would have been better to see it closer to the anatomy and coned in side to side. So marker done. Aesthetics could definitely be improved. Again, we see a bunch of different artifacts over here. So we see this sort of white line. Okay. What do you think that is? And also these little metal straps. This is the patient's bra. They haven't taken it off, probably because they were in too much pain. And these little scraggly lines over here, that's the patient's clothing. You can see one line going through there and probably something up here which we can't see, but that's okay. So in terms of aesthetics and artifacts, could be improved. There are artifacts on the image, the underwire of the bra and the straps on the shoulder do need to be taken off, but in this case, it's answered the clinical question, so we don't need to repeat. So done, not ideal. And N for name, there is no name or identification seen on this image for anonymous reasons. And so we talked about the pathology already, and so obviously the pathology isn't here. We would say this is the distal humerus area, where it's distal, it's further away from the center of the body. Okay, towards the shoulder would be proximal humerus. This area would be distal humerus. And so this is one type of long bone fracture. I would probably characterize this as a spiral fracture. Okay, so it kind of goes over here and then goes around. Now, they do look sometimes similar to oblique fractures, but when they have these sort of sharp edges like this and it's not specifically straight like that, then it's usually characterized as a spiral fracture. I have made a separate video on long bone fractures, so check that out and I'll leave the link down below for you. Okay, so that x-ray is done. Nothing else to really talk about. Let's move on to the next one. Okay, so a lot going on in this one. Hopefully I don't have to tell you that this image could definitely be improved. However, you know, we've answered the clinical question, I guess, so maybe it doesn't need a particular repeat in this case. So what are we looking at? We're looking at, once again, a left humerus x-ray, okay? Where we see sort of the shoulder, you know, the shoulder humeral head over here. We see the scapula, we see the clavicle down towards the elbow joint, and then we see the radius and the ulnar over here. Okay, fantastic. So that's what we're looking at. Now let's go through the PACEMAN criteria. How is it positioned? Well, I'm actually not sure if this is meant to be an AP or a lateral, because ideally for an AP you have the arm down and sort of straight like that. For a lateral, we do have the arm like this, but the patient is in PA. And so it's not really clear what's going on in this case, because it could have well been an AP that was taken like this because the patient is in a cast or some kind of sling that they're not able to move from. And so, you know, you can tell by that because usually the radius and ulnar should be down here, but it's kind of up here. So I'm going to assume this is an AP, although I could be wrong. It could be a variation of the lateral. But either way, the positioning isn't ideal. So, you know, done, but not ideal. However, with the caveat that maybe this is the best that the patient could have done given the circumstances. Okay. What about area? Have we covered from the shoulder to the elbow joint? Well, here's the shoulder joint and here is the elbow joint. So yes, we have covered everything from that. So area is done. Okay. Collimation, again, collimation top to bottom is quite good, just above the shoulder and just below the elbow. Side to side could definitely be improved, specifically more medially. Okay, so laterally, not too bad. That's, you know, within normal limits. But anything, you know, all of this, not needed. So they could have centered a little bit more on the humerus itself and coned in side to side to even get a better quality x-ray. Collimation done, could be improved. Now exposure. Exposure definitely could be improved here. Immediately what you would have noticed is that this is a very contrasty image. There's a lot of whites and a lot of blacks. That typically indicates a low KVP. So if you had to repeat this x-ray, the first thing I would do is bump up the KVP by 5 to 10 points at the minimum, okay? Because it looks like the patient does have some kind of, you know, cast around the elbow, or around the humerus rather, and these are, I think, the part of the cast itself. So anytime you have that, whether it's for an elbow, humerus, wrist, you typically increase your KVP by at least 5 points. Okay, so exposure, and also the contrast aside, it does look like it is quite grainy. Okay, so like quantum mottle, I zoom in. Now this may be, oh, that's the previous one. Now this may be because it's a, you know, picture from the internet, I don't know. But assuming that's not the case, the MAS could have also been bumped up just to get a better signal to noise ratio, okay? More signal, more photons with respect to the level of noise or graininess that you see, okay? So signal to noise, by the way, is SNR. That's a way of sort of knowing how well what the quantum mottle in the image is, okay? So definitely increase KVP and also potentially MAS for this particular X-ray. So done, could be improved. Marker, there was no marker. This is the one sort of I drew in here, but ideally they would put a left marker in this particular case. If it is an AP, then you would have put the marker correctly facing you. However, if it was a PA and the person was doing it erect, as in they were standing up, you would typically do that with the patient facing the board, and in that case you would flip your marker. Okay, so instead of it looking like this, it would look like this, because then when the image is flipped, it looks normal. Okay, so that's what you would typically do for a marker. So marker done, but definitely not there, so it could be improved. Aesthetics, definitely could be improved. The main thing in this case would be positioning and exposure. Okay, given the patient situation, I will definitely increase the KVP next time, and also a little bit in the MAS. I try to collimate it a little bit better, and maybe try to get the forearm down as best as possible to try to get a true AP profile. Okay, because this area looks like it's nice and AP, but the elbow area looks like it's a lateral, so because of the position of the forearm, so that's not ideal. In terms of artifacts, I would just say, if you want to call this an artifact, that would be it. There doesn't seem to be any metal underwires for the bra, so other than that, not really. I'm really not sure what this thing is over here. Okay, it might be something I'm not picking up, but anyway, not the best aesthetics, could definitely be improved in multiple fronts. And lastly, name. There's no name or identification seen on this X-ray for anonymous reasons. Okay, so let's talk about the pathology. Obviously, the big elephant in the room is the pathology right in the shaft of the humerus. And again, this looks like it is a pediatric. You can kind of see the growth plates through here. The sort of elbow joint doesn't look like it's fully formed yet. And again, this one, you see a very sharp fragment over here. Would probably describe this also as some kind of spiral fracture that is mildly or moderately displaced from its original location. Okay, so that's all I have to say about this one. Hopefully that made sense. Let's move on to the next one. Okay, fourth case. In this case, we are looking at what are we looking at? Humerus, chest, neck, what is it? Okay, so we're looking at basically a right humerus, okay, right humerus, and this is an X-ray of a baby. Okay, in case you couldn't tell, the shoulder joint is barely formed, the elbow joint is barely formed, but we're assuming that this was a humerus X-ray, a right humerus X-ray of a baby. Not sure how old, but get the idea. Now, let's go through what the critique is. So in terms of positioning, is it well positioned? Yeah, it's in the AP position. Now the forearm itself may sort of be twisted a little bit, but that's okay because the humerus looks like it's in AP. This would basically the shoulder and the elbow joint over here. So position is quite good. Nothing to really complain about there. Is the area ideal? Well, it's definitely included the shoulder and the elbow joint, okay? Shoulder joint, elbow joint, but it's also included all of this stuff. Now, all of this stuff is not really necessary. Ideally, they would have just coned or collimated the X-ray light beam diaphragm to that, and that would have been perfectly adequate, okay? But again, sometimes easier said than done because pediatrics move a lot. You collimate tightly, you might cut something off and then you have to repeat. So that might even be worse. Anyway, so ideally not including most of the chest in there, chest and ribs and the neck, part of the abdomen. So all of this is not ideal in terms of area covered. Okay, so done, but definitely could be improved. Similar with the collimation, top to bottom is quite good, okay, but again, side to side. So right now, that looks like the center of the image, okay, is about here, okay, and really should have been something like that. Now, I will say, you see the white outline of the image, that's how the image came, which usually suggests that the image was actually, this was the original collimation, and then they sort of coned it down to this in post-processing, which in this particular case doesn't make too much sense because if you're going to cone it down, why not bring it all the way down here? But that's something to take note of, okay? So collimation done, definitely not ideal, could be improved. In terms of exposure, again, focusing not on the chest because that, if that was the focus, it's definitely underexposed. Looking at the humerus itself, adequate contrast, okay? Very little noise I see in the image, so I actually wouldn't change much in terms of, you know what, I would probably say maybe bring down the KVP a little bit to make it a little bit more contrasty, but other than that, I wouldn't really change much in terms of the KVP and the MAS. So happy with the exposure, assuming it was properly collimated and centered on the humerus itself. Marker, the right marker is placed here digitally, so that's the correct marker. It's facing the correct way. It doesn't say whether it was done erect or supine. patient's quite young that it may have just been done supine. But again, usually these things, we don't necessarily need to say it because there's no air fluid levels or anything that we need to look at, as there would be with like an abdomen x-ray, for example. So marker is done pretty good. Ideally, you put the actual physical marker there, but digital is also quite nice. Aesthetics and artifacts, do we see any? Obviously the aesthetics is not ideal because of the excessive collimation sort of in this particular area, which would have been good to remove. But other than that, exposure is pretty good. It is in AP, true AP profile. And there doesn't seem to be any artifacts necessarily. Okay, now this bone here, that looks like the thumb of the mum trying to hold the chin in the other way. So usually we try not to x-ray the patient's parents, but sometimes it's unavoidable. So aesthetics and artifacts done, but definitely could be improved. And lastly, name. There is no name or identification seen on this x-ray for anonymous reasons. Now, is there any pathology on this x-ray? Hopefully you saw something on the humerus. And so it's actually in this area here. This is kind of hard to tell what exact fracture it is. Again, it looks like a transverse fracture. There's a bit sort of poking out there. And the area itself is the surgical neck area of the humerus or the humeral head. So that's how I would describe the position of it, and maybe like a transverse fracture through that area. And so that's all the pathology that I see in this particular x-ray, at least for this humerus x-ray. And hopefully that made sense. Okay, now let's move on to the last one. Okay, last one. So hopefully you're getting the hang of this at this stage. In this case, what are we looking at? We're looking at a right humerus, patient probably standing up erect for this one. What do we see? Let's go through positioning. Actually positioned quite well. Looks like it's in true AP profile. We see an AP profile of the humeral head and the elbow in this particular area, so happy with that. Positioning is quite good. Area, have they included the shoulder joint and the elbow joint? Well, definitely the shoulder has been included and the elbow has been included. Excellent. But it's also included a bunch of other things similar to the previous x-ray that may not have been needed over here. Okay, so area, it's covered what it needs to, but maybe a bit excessively. Collimation, similar to what I just talked about. Looks like the centering of this particular image is around there. Okay, and it's sort of coned out, but really it should have been here and just collimated to the actual humerus itself. Okay, that's what it should have been. So collimation, not ideal, but we could definitely be improved. Exposure, okay. Now, one of the reasons exposure turns out not ideal is because of how bad a collimation could be. It increases the scatter in the image and therefore makes the image look hazy and noisy. Okay, and so again, if I just zoom in to the humerus itself, pretty good, not too bad. I see the bone texture over here. We obviously see some metal work, so we'll talk about that in a second. But in terms of the bone itself, it's not too bad. What I will say, even though the contrast and the noise levels is quite good, the contrast could be improved slightly, and that usually is a result that haziness that you see on the image is a result of the increased scatter. So definitely all of this excess, okay, could have been improved, just been removed, and that would have definitely increased the image quality. Okay, so again, looking at the patients, we see obviously the humeral head, we see the scapula in this area, we see the ribs coming down, we see the clavicle, the ribs coming down to about over here. This is the patient's breast shadow. Okay, we see the hip area, and these sort of lines here typically indicate some what they're wearing. So going tight around the abdomen. We see a bit of the lumbar spine over here. We see the thoracic spine. So we see a lot. Okay, and ideally it shouldn't be like that. And obviously sort of the muscle layers inside, and then the skin around. So definitely could be improved in terms of its collimation, but that's why it's also affecting the exposure a little bit. Not to mention the metal work in the arm. Anytime you have metal work, whether it's in the shoulder or whether it's in the knee, if a total knee replacement, you generally want to increase your KVP to counteract the metal that's inside of them. Okay, so exposure could be improved, but I feel like it's probably because of the centering and collimation. Marker, the right or correct marker is placed up here. Again, would have been better to have it closer to the anatomy and cone it in. Okay, always, that's the ideal situation. In terms of aesthetics and artifacts, and you can see these little squiggly lines. This is probably the patient's clothing. You can see all these little straps over here. It's patient's clothing that didn't have any metal, so it's not too bad in that sense, but you know, that it is what it is. In terms of aesthetics, the only thing that would improve it would be to fix the collimation and remove all of this stuff immediately, and that would have improved image quality, definitely. So done, but not the best. Name, there's no name or identification seen on the x-ray for anonymous reasons. And so really what we see in this x-ray is a healed fracture, okay? So this is post-op, I don't know how many weeks, looks like it's at least 6 weeks has passed, but the fracture was in this area, okay? So you can see the healed line there. And they've basically had a plate and screw put in to make the humerus nice and stable and for the fracture to heal. Okay, so plate and screw, internal fixation, meaning they had to open the skin to fix the issue. The fixation put everything back together. Looks like, again, it's a little bit lower than where the surgical neck fracture would be. Again, if it was a bit lower than that, you would just characterize that as some kind of transverse fracture of the humerus, which is a long bone. Okay, so that's basically it for this x-ray. Hopefully it made sense, and hopefully you learned a lot in terms of what to look for in humerus x-rays, what not to do, how to improve things, and a bit of the pathologies that we talked about. Now click the video on the screen to watch my previous critique, which was on the elbow. Go through a lot of different cases, and I think you'll find it quite interesting. All right, see you in the next one. Stay curious.